My name is Nancy Good-Kennedy. I am the registered nurse with the North Simcoe Muskoka Hospital Palliative Care. With the COVID-19 coming, then we're liable to see a lot of chest infections, a lot of pneumonias. So the presentation today will focus on symptoms closely related to pneumonia in particular. I also would like to share that most of my information today does come from McMaster. However, along with McMaster, I also use Palliative often, and you'll often see my. So as you can see, when I speak of topics of interest, goals of care is right up there. We'll just get right into the meat and bones of things. So the goals of care, dyspnea, treatment of agitation, and of course, palliative sedation. So the guide for serious illness conversation. I'm sure many of you have either gotten this given to you by either myself or one of the other palliative practitioners. It tends to be a little bit of a go-to for us. It's bases itself on you actually being in touch with the patient and understanding that in order to get the feedback that you're requiring, it's about gaining trust, basically. And if you set that conversation up, meaning invite your patient into your space and vice versa, be sure that you have consent from that patient to be in their space. So my goal is always to try and balance the hopes and expectations with the medical realities of their situation, and this is really where the art of palliative care will come into place for you. Often I hear that independence, communication, cognitive awareness, spending time with loved ones, and being free of suffering are goals that people want to talk to us about. And it's important that we have the knowledge, the skill, and the judgment to help them make that happen. So being able to guide a serious illness conversation is a very small piece of helping that puzzle unfold. So we know that we're often working with the vulnerable population, and really life support often leads to more suffering and not always what they want themselves. They don't usually have much of an interest in extending their life, especially if it's not going to be in a meaningful way. But it is important that the steps be ironed out with them, and we do things in keeping with what their values are. These frameworks help you establish a flow of conversation, and that flow will happen. It just takes time and time to get used to a tool that works for you. So again, just to review through the PowerPoint, the first is to set up your conversation, assess their level of understanding of what's happening, share the information and prognosis that you have, just as long as you have done all of your homework and you've consulted with your attending physicians and your palliative team have been together and had a discussion about what that prognosis does look like, then certainly by all means, it is within your scope to share that prognosis. So you'll want to explore those key topics talking about their goals, their fears, the things that they're afraid of. And sometimes it takes a while for that ice to break, but when it does, you'll be really surprised at the relationships that you form yourself with your patients. It's very rewarding, as I know you people are working very hard to keep the home front clear there, and I know that you've developed these relationships in the past. It's just with COVID-19, there is a lot of stress, and it's showing us that often patients do, once they get on that trajectory, some depending on, of course, their comorbidities, but it seems as though the process can be quite rapid. We just want to help you be prepared in the best way that we can. Okay. So we know that some of the symptoms, or one of the main symptoms, the dyspnea that comes along with respiratory infections, can be cause agitation, and we'll talk about that as we go through this program tonight. However, treatment for dyspnea in our opioid naive, you can use that morphine as the gold standard, and you'll pardon me, convert everything back to morphine anyhow. But typically we would start, when we weren't really working in COVID, we would give PRN doses and calculate that over a 24-hour period and then try to get them onto a regular dose. But now protocols are changing a little bit more aggressive, and they want you to use the dosing every 4 hours, especially if this is obviously a patient that's in great distress. We're talking an active COVID patient. So you would start with your 2.5 to 5 and also add the breakthrough in, and either morphine or hydromorphone are the meds of choice. If your patient's already taking the opioids, then you'll increase what they had been on previously by 25%, and then your breakthrough will be 10% of your daily total. I know you guys have heard me talk about this before, and you're going to give that every hour, and every hour if they need it, as the PRN. 30 minutes if it's sub-Q. Okay, so if those meds aren't effective, then we're going to look to titrate, increase regular doses by 50%. And when I first saw that 50%, I thought, again, that's just a little bit more aggressive. I probably would have been between the 30 to 40% prior to working with COVID. So we all know that if dyspnea is not controlled, it can cause a lot of anxiety and a lot of agitation, because one just typically leads to the other. So I think one of the best pieces of advice that I could share with you would be talk to your patient. It's a great idea if you can have that comfortable conversation kind of lined up ahead of time. Obviously, you're going to reassure your patient and just let them know that you're going to be right there beside them. You're not going to leave them. You do have medicine that will help them, will help make them comfortable. And again, it's about gaining their trust, right? So there is the skill of the breath, 1, 2, 3, 4 in, 1, 2, 3, 4 out. That's not by any means going to stop their breathlessness, but what it is going to do is take their mind off it for that very short period of time, for you to be able to look them in the eyes, talk to them, help them with their breathing while you have a partner that is hopefully able to run and draw meds for you. So if the patient's condition improves, the good thing is we can always reduce and taper and reduce, right? So that we always have that to look forward to. Again, the anxiety, if the opioids aren't effective, the dyspnea crisis, then the Nosnan or midazolam. And you'll want to have a review if they're using any more than 4 PRNs in 24 hours. If you have tried your other meds and things aren't settling down, we then look at a palliative sedation. And continuous palliative sedation is definitely, you need consent. You need to explain very, very well to your patients what this is going to look like, and families will need a lot of support. In some patients, symptom relief may be achieved at a very light level with a smaller amount of sedation. Other patients, you're going to see that they require a higher dose. So a symptom is considered refractory if it can't be adequately controlled without using the sedation. So you've tried everything else, basically. And now it's time to move toward something a little bit deeper. So the criteria for palliative sedation is the life expectancy is about days to 2 weeks. And I myself have never seen a palliative sedation last up to 2 weeks. And I'm not saying that it doesn't happen. I'm just saying that I have not, I've not seen that happen. So again, informed consent, and be sure that the patient understands that there will be no CPR and that there has been an agreement to allow a natural death. Optimize usual treatments that have failed in the past, and the alternative effective treatment options are either not available or can't be managed within the time frame. The patient obviously is very symptomatic at this stage. So the process, the patient assessment is one of the, always in any nursing skill, important, very important. Review the goals of care, make sure that you have your informed consent, and make sure that you're documenting. And when you review the medications, which ones are essential to continue? So the pain medicines, they're now going to be required to delivery for sub-Q or IV administration. And then you're going to talk also about which meds you're going to discontinue. So those would be anything that's not being used particularly for symptom control. So again, you're going to determine and document the level of sedation that you've agreed upon after conversation with both the patient and family, depending on whether the patient obviously is able to involve themselves in making these decisions. So you want to ensure that the monitoring is taking place, that you've talked about parameters, the method, and the frequency, and you've double-checked your orders. You want to communicate with the patient, the family, and the substitute decision maker. Talk to them about what it's going to look like as sedation starts, and that, again, just be sure that you are have allotted time to be able to spend with this patient and family, because this is a very new process for them. It may not be for the nursing staff, but it certainly is for family, and they're going to see a different stage happening. They're going to, as I said, require a lot of support. So the medicines that you're going to use, we have a first line and a second line, and within the first line there's 4 different options. So the first line, first option is Nosenan, 25 milligrams sub-Q, 12.55 in the frail and the elderly, and around the clock you're actually going to give a routine dose as well, with a PRN of a midazolam. Your second option, which we don't see a lot of, is the lorazepam, sub-Q or IV. We always talk about lorazepam and the elderly, and probably not one of my favorites, but it's here in the dosages. The dosages are all here for you. So the option number 3 is for the midazolam to be given sub-Q through intermittent injections. And option number 4 is that the midazolam be given by continuous infusion. The usual dose that's required is the 1.5 milligrams an hour, and the higher doses may be required in select cases, but just be sure that you're assessing and documenting, assessing and documenting, assessing and documenting. The care plans are very clear, and there will actually be new order sets coming from the palliative planning team. So this will come to you in a formal document on the units as well. So the second line, if options 1, 2, 3, and 4 are not effective, then that's when we add the phenobarb. You'll always give the stat dose, and it will depend upon the severity of the situation, obviously. And then you're going to have a standard dose that you're going to give twice a day. Just remember that it has a long half-life. It doesn't allow for rapid titration, so it does take some time to make that happen. I want to just leave some information here that if you need any further support, please call me at any time. I'm always available. I am available for OTN work as well, so don't be shy. 705-325-0505, and my extension is 104. Also, if you need resources in the hospital and I'm not present, I do share an office up on the 2nd floor with night supervising and the Falls program, and there are resources, and you're welcome to source those out for your patients. These are the resources that I used. There are also a few links on the COVID-19 North Simcoe Muskoka Hospice Palliative Care Network site, and that changes daily. It's updated routinely, so certainly please check that out. Thank you very much, and I hope you all have a great night. Take care. Bye-bye.